If you were to, like, just grab a jar of raw coconut oil from your kitchen pantry right now, to use as a personal intimate lubricant, you would essentially be introducing a Trojan horse of dormant bacteria straight into your body's most sensitive ecosystem.
Yeah, it is a really sobering reality check, honestly.
Right. And not only that, if you paired that kitchen oil with a latex condom, you would completely destroy that barrier's structural integrity in like under 60 seconds.
Which is wild because, the wellness space has so heavily pushed this narrative that natural is universally safer.
Oh, absolutely.
We see this ingredient marketed as a total cure-all, but placing a culinary product into a highly complex mucosal environment, it just triggers this massive chain reaction of chemical and biological disruptions.
And that tension, right, between internet hype and clinical reality, that is exactly what we are unpacking for you today.
Yeah, we have a lot to get through.
You do. We've got this huge stack of dermatological research, clinic protocols, guidelines from the International Society for the Study of Vulvovaginal Disease, the ISSVD.
Right, the gold standard guidelines.
Exactly. And our mission for this deep dive is to answer a really highly debated question for you. Can coconut oil actually help manage lichen sclerosus?
It's a question we see all the time.
Constantly. So we're going to bypass the typical, surface level internet advice. We want to really examine the pathology of the condition and look at the actual cellular and molecular mechanisms of how these treatments interact with human tissue.
Which means, to evaluate any intervention, we first have to establish the baseline pathology.
Right. What are we actually dealing with here?
Well, according to the ISSVD classification, lichen sclerosus, or LS, as we'll call it, is a non-neoplastic, non-infectious vulvar dermatosis.
Okay, let's unpack this.
Yeah.
Because that's a lot of medical jargon.
Fair enough, yeah.
Yeah.
Fundamentally, it is a chronic, cell-mediated inflammatory disorder. The current consensus points really heavily to an autoimmune mechanism.
Meaning the body's attacking itself.
Exactly. The T cells mistakenly target the basal layer of the epidermis.
I was looking at the histological descriptions in the literature, and there's this fascinating and honestly terrible paradox in how it physically manifests.
The hyperkeratosis.
Yeah. The chronic inflammation triggers hyperkeratosis, so the outermost layer of the skin actually thickens, right? But simultaneously, the underlying dermis goes through this massive structural degradation.
Right, the collagen in the upper dermis basically becomes homogenized. It completely loses its elasticity and structural integrity.
So having LS is like your skin turning into delicate, wet tissue paper that's constantly irritated by everyday movement.
That is a very accurate, if painful, analogy. Yes.
Yeah.
While the surface might feel thickened or scaly, the tissue as a whole becomes incredibly fragile.
Which really explains the primary physical symptoms. I mean, the intense, unyielding pruritus, the itching, and just severe pain.
Yeah, because the skin has lost its tensile strength. So just simple friction from, like, walking or sitting causes microscopic tears. We call them fissures in the vulval tissue.
And the long-term consequences of leaving that unchecked are pretty profound, right?
Oh, absolutely. We see progressive anatomical changes over time. So the resorption of the labia minora, the baring of the clitoris, and severe labial fusion.
Where the tissue actually scars and physically fuses together.
Making sexual intercourse and even just urination agonizing. And crucially, there is a known 3 to 5% risk of this chronic inflammatory state progressing to squamous cell carcinoma.
Wow. And that progression risk is exactly why relying on a kitchen-grade moisturizer to treat an autoimmune condition is so alarming to me.
It's a massive risk.
I really want to push back on the wellness community's messaging here. If the fundamental driver of LS is an aggressive T-cell response destroying the epidermal junction, surely a simple moisturizer can't fix it. I mean, laying down a barrier of coconut oil isn't doing anything to stop that biological cascade.
No, it isn't.
It's like trying to fix a sinking concrete foundation by just installing a really nice carpet over it, right?
That is exactly it. A structural failure requires a structural intervention. The established gold standard first-line therapy across all the dermatological guidelines is the aggressive use of ultra-potent topical corticosteroids.
But the heavy hitters.
Right, specifically clobetasol propionate, 0.05% ointment.
And the goal there is to literally shut off the immune response.
Exactly. The pharmacological goal is to bind to the glucocorticoid receptors in those inflammatory cells, which inhibits the transcription of inflammatory cytokines. You literally have to shut off the immune attack at the source.
And the standard regimen for that clobetasol is usually, twice a day for up to 12 weeks?
Usually, yes, before tapering down to a maintenance dose. But, and this is a big start, but steroids of that potency carry their own well-documented side effects.
Right, particularly corticosteroid-induced skin atrophy. So the medication you are using to stop the skin from scarring can also thin the skin over time.
Which is incredibly frustrating for patients. And what's fascinating here is that this risk profile is a major driver behind the search for adjunct therapies.
People want relief without constantly using the steroids.
Exactly. Patients are trying to manage their daily discomfort while minimizing their cumulative steroid exposure. And furthermore, there is an entirely separate complication with standard medical emollients.
Oh, right, the petroleum derivatives.
Yes. The base vehicles used in a lot of prescription steroid ointments and pharmacy-grade moisturizers rely heavily on things like white soft paraffin.
Which introduces the risk of contact dermatitis for some people.
Exactly. For a subset of patients, the paraffin itself triggers an allergic response.
That's awful. Meaning the very vehicle designed to deliver their medication or soothe their skin causes a massive inflammatory flare-up.
Right. So when a patient cannot tolerate paraffin, the treatment landscape narrows significantly. And this is the precise clinical gap where coconut oil enters the conversation.
Okay, so it does have a legitimate medical context.
It does. Guidance from the whole university teaching hospitals highlights coconut oil as a viable, natural, alternative emollient for patients who are sensitive to standard petroleum bases.
Yeah, I saw that. And the whole university data specifically calls out the presence of caprylic acid in coconut oil.
Yes, that's the key component.
I know caprylic acid is like a medium-chain fatty acid, but I'm struggling to see why that specific compound elevates coconut oil above other natural alternatives. Like, why not just use olive oil or almond oil?
It all comes down to the molecular structure. Caprylic acid is an 8-carbon saturated fatty acid, and it is highly amphiphilic.
Okay, amphiphilic meaning.
It has a lipophilic end that can easily integrate into the lipid bilayers of certain microbial cell membranes.
Oh, so it physically wedges itself into the bacteria.
Precisely. When it inserts itself into those membranes, it disrupts their structural integrity. It increases membrane fluidity to the point where the cell contents literally leak out.
Oh, wow.
Yeah. This gives coconut oil demonstrable, albeit mild, antimicrobial and antifungal properties that a lot of other carrier oils just lack.
So for a patient with fragile, micro-torn skin who really needs a protective lipid layer to, lock in moisture and reduce friction, it provides a functional barrier with a slight, localized antimicrobial benefit.
Exactly. It's a great barrier.
But wait, the Women's Health Clinic makes it very clear that there is no robust clinical evidence that coconut oil improves the underlying inflammation. So relying only on coconut oil is like putting a fresh coat of paint on a house that's actively on fire, right?
Yes, the clinical consensus is absolutely unanimous on that point. Coconut oil is strictly an adjunct therapy.
It's just for symptom management.
Right. It manages the mechanical symptoms, the dryness, the friction, but it does not alter the disease trajectory. Delaying effective steroid treatment to experiment with natural oils allows the irreversible architectural damage of the vulva to continue.
Okay, so let's transition to the practical application then, because the sources raise a massive red flag about the type of oil people are actually using.
Well, the kitchen oil problem.
Exactly. Here's where it gets really interesting. The instinctive move for someone reading about this online is to just walk into their kitchen, grab the jar of food-grade raw coconut oil they use for baking, and, well, apply it to their vulva.
Which is incredibly risky.
The biological implications of that are actually terrifying when you look closely at the microbiology of a kitchen environment.
Yeah, you have to consider water activity, or AW, in food products. Raw coconut oil is essentially 100% lipid.
Right. There's no water.
Exactly. It lacks the free water necessary to support active bacterial or fungal growth, but that doesn't mean the kitchen environment is sterile.
Right, because you're using a spoon you cooked with, or just dust in the air.
Exactly. Airborne spores, mold, and bacteria introduced from the kitchen don't die in the oil, they just go dormant. They remain in a state of stasis.
Because they lack the water needed to germinate. But the moment you take that unsterilized oil and apply it to the mucosal tissue of the vagina, you are introducing those dormant kitchen microbes to a warm, highly vascularized environment with abundant moisture.
You are providing the exact physiological conditions necessary for those spores to wake up, germinate, and colonize.
And the threat is compounded by how coconut oil chemically interacts with the vaginal microbiome, right?
Yes, the pH disruption is significant.
Because the vagina is naturally acidic. It maintains a pH between like 3.8 and 4.5.
Right, and that acidity isn't an accident. It's actively maintained by lactobacilli bacteria converting glycogen into lactic acid. It's supposed to be a hostile environment for exogenous pathogens.
But raw coconut oil is highly alkaline.
Exactly. So when you apply it internally or heavily around the intratus, that alkaline lipid layer neutralizes the local lactic acid.
Oh no. So it shifts the vaginal pH upward.
Yes, creating an environment where the protective lactobacilli are suppressed and opportunistic pathogens, particularly Candida albicans, the yeast responsible for thrush, can just rapidly overgrow.
Wow. So for an LS patient who's already dealing with severe inflammatory pain and microfissures, triggering a severe yeast infection by disrupting their pH with an alkaline kitchen oil is like an absolute nightmare scenario.
It's the last thing they need.
So using kitchen coconut oil is basically bringing a Trojan horse of dormant kitchen bacteria into a highly sensitive, perfectly balanced acidic ecosystem while simultaneously destroying your latex condom.
Yes, the condom issue is huge.
Let's talk about that 1989 study, because the interaction between coconut oil and barrier contraception is terrifying.
That study on the degradation of commercial latex condoms remains a foundational piece of sexual health literature, and yet it is routinely ignored in natural wellness circles.
The methodology showed how rapidly mineral and plant-based oils compromise polyisoprene, right,
Mhm.
which is the primary polymer in latex.
Exactly.
And the timeline of the structural failure is what stopped me in my tracks.
Hmm.
Exposing a commercial latex condom to oil can decrease its efficacy by up to 90% in just 60 seconds.
60 seconds.
I'm trying to visualize the chemistry of that because the latex isn't melting in a thermal sense, is it? It's a catastrophic structural failure at room temperature.
Right. It is driven by hydrophobic interaction. The latex polymer chains and the lipids in the coconut oil are both highly hydrophobic.
So they repel water, but they love each other.
Exactly. When they come into contact, the oil molecules readily slip into the spaces between the polyisoprene chains of the latex. This increases the free volume within the polymer matrix, basically forcing the chains apart.
So the oil literally wedges itself into the microscopic structure of the rubber, swells it up, and completely destroys its tensile strength.
Within a minute, a barrier designed to withstand significant mechanical stress turns into a weak, gelatinous mess that will readily rupture under friction.
You are risking the transmission of sexually transmitted infections and unintended pregnancy entirely under the false assumption that a natural plant oil is a benign substance.
It is incredibly dangerous.
The physics of that interaction are just undeniable. So, okay, if we accept that prescription steroids are mandatory to halt the disease, and we acknowledge the severe microbial and chemical dangers of using raw kitchen oil, how do patients actually manage the daily mechanical symptoms of LS?
Right, because the structural integrity of their skin still requires support.
Exactly. What is the golden middle path here?
The clinical guidelines really shift the focus from just a quick topical fix to a comprehensive management protocol. So, for example, the Lichen Sclerosus Guide emphasizes the elimination of standard soaps entirely.
Right, because the surfactants in normal body washes strip the natural lipids from the skin.
And an LS patient simply cannot afford to lose those lipids.
So the alternative is what, emollient washing?
Yes. You take a safe, medical-grade emollient or a properly sterilized formulated oil, mix it with warm water in your hands, and use that emulsion to cleanse the area.
It removes cellular debris without disrupting the skin's natural barrier function.
Exactly. But the timing of applying these barriers is arguably the most critical piece of daily management, particularly the 20-minute rule.
I noticed that. The whole guidelines stress that 20-minute gap.
It's vital. When a patient is using their clobetasol ointment and an emollient or coconut oil on the same day, the pharmacological sequencing matters immensely.
I initially thought it was just to prevent the products from physically smearing together. But the pharmacology here is actually about absorption gradients, isn't it?
Yes, exactly. The pharmacokinetics of topical steroids depend on maintaining a concentration gradient to cross the stratum corneum. If you apply an occlusive layer of coconut oil first, or simultaneously with the steroid, the oil creates a physical barrier.
Trapping the active medication outside the target tissue.
Precisely. The steroid must be applied directly to the clean, affected skin and given at least 20 minutes to fully absorb into the epidermis.
Only then can you safely apply the emollient over the top to seal in moisture and protect against friction.
Yes, and managing that friction extends beyond just topical
Right,
applications.
the physical environment of the tissue has to be controlled. Things like wearing 100% cotton underwear, avoiding tight clothes.
To minimize ambient heat and mechanical shearing forces, but the intervention that seems to offer the most immediate mechanical relief is actually the use of a peri-bottle during urination.
Right, because the chemical composition of urine, the urea and salts, is highly irritating to torn skin.
Extremely irritating. When urine passes over the microscopic fissures characteristic of LS, it rapidly triggers the local nociceptors, causing intense burning pain.
And a peri bottle is just a small squeeze bottle with an angled nozzle, commonly used postpartum, right?
Yes, by filling it with warm water and gently irrigating the vulva while urinating, the patient alters the specific gravity of the urine in real time.
It dilutes the concentration of those irritating salts and urea before they have a chance to sting the torn skin.
It is a brilliant non-pharmacological application of basic fluid dynamics that dramatically reduces the daily pain burden for these patients.
That's incredibly practical. So what does this all mean for listeners who don't have LS but still experience severe dryness?
Well, if we connect this to the bigger picture, while lichen sclerosus is a highly specific autoimmune pathology, severe vaginal dryness and mucosal atrophy are incredibly common across the board.
Right. Looking at the oncology research in our stacks, specifically the breast cancer data, we see women dealing with catastrophic tissue changes.
Yes, patients undergoing endocrine therapy for hormone receptor-positive breast cancer, often using aromatase inhibitors, experience a profound systemic depletion of estrogen.
And estrogen is the primary hormone responsible for maintaining the thickness, elasticity, and glycogen production of the vaginal epithelium.
Exactly. When you remove that estrogen, the tissue rapidly undergoes atrophy. It becomes thin, dry, and highly susceptible to trauma.
Leading to severe dyspareunia or painful intercourse, which is what makes the pilot study on the Coca Relief Protocol so significant.
The data from that protocol is compelling. In a cohort of patients suffering from severe dyspareunia due to menopausal or therapy-induced vaginal atrophy, 83% of participants reported that the protocol significantly improved their symptoms.
Wait, really? An 83% success rate for a non-hormonal intervention in an oncology population? That is massive.
It is, but, and this is crucial, the protocol doesn't use raw kitchen oil. It relies on virgin coconut oil that has been specifically prepared and formulated for internal medical use. The formulation process is what bridges the gap between a culinary ingredient and a medical adjunct.
Okay, the source material highlights products like, it's EAS cocoa.
Yes, products that take organic coconut oil and purify it in a sterile manufacturing environment, completely eliminating the risk of dormant bacterial spores.
And they also blend it with other biocompatible lipids like jojoba oil.
Exactly.
Jojoba is fascinating because its wax ester profile closely mimics human sebum. So by blending the caprylic acid-rich coconut oil with sebum mimicking jojoba, the manufacturers create a highly stable, bioidentical lipid barrier.
It delivers the deep tissue nourishment and prolonged mechanical glide required to prevent microtrauma during intimacy. And it does this without the catastrophic pH disruption or microbial risks associated with raw alkaline kitchen oils.
So it's a really powerful tool for menopausal symptoms, general painful sex, and as an adjunct barrier for conditions like LS.
Absolutely, when formulated correctly.
Well, that really brings us to the overarching takeaway from our deep dive today for you listening. Treating chronic dermatological conditions requires precision, not just intuition. Coconut oil is unequivocally not a magical cure for lichen sclerosus, and it absolutely cannot replace the high-potency topical steroids required to halt that autoimmune destruction.
No, it cannot.
Trying to use it as a primary treatment just invites permanent architectural damage to the tissue. But when sterilized, properly formulated, and used correctly in conjunction with a strict pharmacological regimen, meaning you respect that 20-minute absorption window, it is a fantastic caprylic acid-rich barrier. It can soothe dryness, protect against friction, and really improve quality of life.
The science demands we look past marketing labels. We have built this cultural assumption that a substance labeled natural is automatically assumed to be safer, gentler, and universally applicable. Yet, as we've seen, if our body's highly complex, acidic ecosystems can be completely thrown into chaos by something as simple and natural as alkaline coconut oil, how many other everyday wellness trends might be secretly disrupting the delicate internal balances we take for granted?
Oh, wow. That is a really provocative thought. And that is the exact kind of critical thinking we need to apply to every health trend. Just because a compound is found in nature doesn't mean it is biologically compatible with every human ecosystem. So the next time you look at that jar of coconut oil in your pantry, appreciate its chemistry, but leave it in the kitchen. Thanks for joining us on this deep dive.